When you think about this blueprint for Virginia idea, I can't tell you how, maybe it's going to scare you a little bit, our minds are working in the exact same way. We have to come together around a table to make Virginia competitive and work for all Virginians, and I'm thrilled to be part of this conversation. So, usually when people want me to speak, they want me to bring some report from Washington, so I've been thinking about movie reviews, and if you may recall, remember that movie, Thelma and Louise? And so if you think about what Washington is going through right now, there's a point to this. They have decided to lock arms and ride off into the sunset rather than to actually face the problems they left behind, which is simply a very, I think, simple way of saying we have to solve our problems. They are not going to solve our problems for us. We are on our own here. But all you can do with people who actually believe it's okay for the U.S. to default, which is, I don't want to bore you, but not a good idea. But people who believe that it's okay for the U.S. to default have come to Washington, and some of our people have elected them. There's not much you can do for people like that except pray for them. And when you're through praying, sometimes, I don't know about you, but I don't always feel like I got through, so I watch cartoons. And when you think about this is kind of like the new Rorschach test for the American people. Which of those creatures, you know who we're looking at here, this is Wile E. Coyote and Roadrunner, right? And Roadrunner always makes him chase him and then stops right at the edge and Coyote goes over, right? Which of those creatures looks more like Barack Obama and which looks more like John Boehner? I don't know either, but I'll tell you this, one of them is Wile E. Coyote, and somewhere pretty soon, probably in the fall, gravity's going to start operating. Right? So we have people in Washington who they try hard. Lord knows we're on our own. Okay, so here's why we're in this room. This is a ratio of family premium to median family income. We can talk about the technical stuff, but the deal is in 1996, it took 10.8% of a median family's income. And by the way, I do count the employer contribution as part of income because employer contributions would be its compensation. It would be income if it were not spent on health care. 10.8% in 96 doubled in the last 15 years to 20.9. That means the median family is spending 20%, 21% of what they make to pay for health care. There's a term for that in economics. It's called screwed up. What you have here is a situation we cannot sustain. Now, to get down to the reality of competitiveness, I love this focus. This comes from the Manufacturing Association of America. I don't know if you can make this out, but what this does is it decomposes all the reasons America has trouble competing around the world. And what I want to show you is benefits, most of which is health care, is just as big an impediment to our competitiveness as the corporate income tax. Now, most economists would certainly join the business community and say we should get rid of the corporate income tax. But the point simply is healthcare is as big a burden as a corporate income tax in comparing how we compete internationally. Next thing I want to show you is basically the same thing, everything's going up. This is cost per hour for U.S. manufacturers paying for healthcare, and it's basically gone from $2 an hour to almost $3.50 an hour in 10 years. That's totally unsustainable. And here's the reason we've been having all this excitement. This is, in my view, the single most important number in the healthcare debate in Washington, because health and budget are now basically the same. And what this shows is the ratio of our debt to our GDP, that is what we owe each other and the Chinese, divided by what we produce. So it's like a claim on our income of what we owe, okay? So you go back, and I'm a Southerner, I'm from Arkansas. I didn't grow up here. I am proud to be a Virginian now, but I did grow up in Arkansas. Anyway, I believe history matters. Unlike some people. And I want to take you back to 1940, right? And I don't know if we got a pointer on this thing. Probably doesn't work. Go back to the left-hand side. 1940, debt to GDP was 40%. Then it jumped up to 110% pretty quick. Why? Because we had to borrow to build those battleships to defeat tyranny around the world. And that was a good idea because we faced an existential threat to our way of life. So we once actually had in our nation 110% of GDP in debt. But guess what? Then we paid it off. We went from 110 all the way down to the low 20s. Now, it's not a completely smooth path. Why? Because every time there's a recession, GDP drops, yet the GDP jumps, so there are these little hiccups. But note, the fundamental trend was to pay off our debt. Why did we do that? How did we accomplish that? Well, there was a time, friends and neighbors, when we had a bipartisan consensus about how to get our fiscal house in order. It is possible. We will have to do it again. We went from 110 to 20%. Now, there was a big hiccup in the mid-'70s. How many of you remember OPEC, Yom Kippur War, buying gas on Tuesday, not on Wednesday? There was a big hiccup then, but then we still were only in the high 20s. Then along came 1981. That's kind of a break point. 1981, we started going up monotonically again. What happened in 81? No, the Cardinals were not in the World Series. Ronald Reagan was president. He's a fine American, inspired a lot of us, whooped the commies, tore down the wall. But he also told us we don't have to pay for government. I'll tell you a secret. You got to pay for the government you want. You can have whatever size you want, but you're going to have to pay for it, because he told us that. It went on up. And then along came Ross Perot. Remember Ross Perot? I personally love Ross Perot. He's the only public speaker in America, got bigger ears than me. And he's from East Texas, right? And I'm from South Arkansas. Man has no accent at all. Perfect elocution. I just love the man. And I want you to remember now, Ross Perot used his own money, bought TV time, held up little simple PowerPoints, bang, 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 charts going up, saying, we got to do something about this debt. Now, he was a little too flaky to win the presidential nomination, had some funny theories about his daughter's wedding being bugged by Daddy Bush. But the point is, that little man created the space. He created the space, not unlike what his blueprint's trying to do. He created the space for Clinton and Gingrich to balance the budget. Now note, Clinton and Gingrich, bipartisan. They don't like each other much. They never did, never will. Don't agree on much, but they did agree to balance the budget. Why? Because we had to. And guess what? Started going down. We got debt to GDP down in the 30s again, and then what happened? When Clinton left office, let me remind you, Republican Congress, Democrat president, sound familiar? Clinton left office, $200 billion surplus. Let me say it again, $200 billion surplus. What the hell happened? What happened was a couple of wars we didn't pay for, Medicare drug bill we didn't pay for, and then the recent economic excitement. Now, I'm an economist. I don't want to use the D word, get y'all all scared, but I will remind you in October of '08, go back with me just a moment, October, we were losing 800,000 jobs a month. Little Ben Bernanke, chairman of the Fed, Big Hank Paulson, Secretary of Treasury, together went to Congress at night, both houses, all leaders, interrupted playoff baseball to show me Nancy Pelosi and Richard Shelby. This cannot be a good idea. And you may know little Ben Bernanke is the only economist of my generation spent his whole life studying the Great Depression. When we were young, we all said, Ben, why are you doing that? We've solved that problem. Thank God Almighty George Bush put him in that spot, because he had unique credibility to look at those members of Congress, both houses, at night and say, sports fans, we are this close to, let me give you a technical term for, in the Great Depression, our unemployment rate was 25%. We've been having a hissy fit over 25%, and I promise you that was an understatement, because back then you could go back to the farms. They were kin to you. I'll tell you a secret, farms aren't going to take you back now. We don't have a bottom. So Bernanke said, we have no choice. You have to borrow and spend. Only the federal government's big enough to do this, and that's the last third of that little bump up in the debt. 2/3 of it's the recession itself, 1/3 is the stimulus. The sin was not to borrow when we had to. Why? We face an existential threat to our way of life. The sin is what happens after that. And I stop mercifully at 2030 because I don't want to make you sick before lunch. It keeps going on and on and on. Why? Because we no longer have a bipartisan consensus about how to get our fiscal house in order. Let me tell you a secret. There is no way to do that unless you get healthcare cost growth under control, because healthcare cost growth is the single biggest driver of our fiscal imbalance, whether it's Washington, Richmond, or families' households. And that's why we had to do this. Now, I did tell you I grew up in Arkansas, so unlike you, I did not learn everything I needed to know in kindergarten. It took me till 7th grade. You may remember, 2 roads diverged in a yellow wood. All right? We got 2 choices here. We could just cut. We could just say, we can't afford Medicare, so we're going to cut it by 1/3. We can't afford Medicaid, so we're going to cut it by 1/2. And while I don't agree with Paul Ryan's priorities, I will respect the man forever because he had the courage of his convictions to write it down, and I will say the other side has never been as forthcoming in the consequences of their choices. So you got to give the man that. He's trying to engage a serious conversation. But the alternative pathway is one I find far more attractive, partly because I'm an economist and realigning incentives is full employment for us. Let's be clear about that. But it's also true it's by far the more humane way. Why? Because it links the self-interest of the providers and the people in the system with the common social interest of reducing cost growth, just like this blueprint is trying to get us to. It's the only way out. However, when you think about trying to realign incentives in a system that's complicated, we got 8,000 CPT codes, we got 458 MSDRGs, we got 600 ways to pay hospitals, you would have to have the wisdom of Pericles. You may have heard of Pericles, Golden Age Greece, a couple good decades there. I want to tell you a secret. We don't have Pericles anymore. We have Rick Gilfillan and Barack Obama. They're fine Americans. They try hard. They're smart. They are not Pericles. So we got to solve this stuff ourselves. We got to realign incentives, and that is multidimensional. And that includes taking into account the fact that we got to get the patient involved here. We spend all our time down there in that bottom trying to figure out how to pay the gerbils differently and get them to behave better. But you know what? If we don't get the patient deeply engaged, and I don't mean just broccoli and sit-ups, although that's part of it. I mean make the patient aware of the implications of their choices. That means smart cost sharing. That's what value-based design is about, and there's a lot of that going on in this state, thanks to the leaders on this table. And also decision support. You know, it turns out a lot of evidence suggests very clearly you give patients the full range of options. Most of them actually want the least invasive option. Most of them actually want to die with dignity at home and be with their loved ones as much as they can, as opposed to be hooked up to all those tubes no one can pronounce. But we don't get that choice in the current situation. So we got to do a far better job. And then we got to remember patients don't live in the healthcare system. They live in communities where you either can or cannot buy fresh vegetables, whether you either can or cannot walk safely to get exercise, whether you either can or cannot live in housing that lets you sleep well so you can be more productive at work. We got to think about all that stuff. Now, there'll be an exam on this at noon. These are all the different payment experiments that the federal government's doing. I'm going to leave that to Maryland. But here's the good news about all these. There are two things I'd say. One is, you know, they're all doing the same thing, and that is trying to take us to a better place. That is, pay smarter. Instead of unaccountable fee-for-service, let's pay smarter. And again, link the self-interest of the clinicians, of the providers, with the social interest of reducing cost growth over time. But here's the really good news. The private sector is taking these same ideas and spreading them even faster. This is a map put together by America's Health Insurance Plans. It shows you bundling, patient-centered medical home, ACOs, global payment, all the technical stuff that's being tried by the government is also being done by the private sector. In every state in the union, my whole life, I grew up saying, thank God for Mississippi. Because while we in Arkansas were 49th at everything, they were always 50th, and by God, we could beat them. So I must say I used to love using this chart because until a month ago, Mississippi didn't have a darn thing going on, but they went across the river and stole a medical home from Arkansas, and now they got one too. But the point is, everybody in the country's gotten the memo. We got to get smarter about how we pay for health care. But I got to tell you, the budget world is skeptical. Why? They've heard this stuff before. Think about all the buildup around accountable care organizations and how that was going to be the ticket to nirvana. That was going to be the solution. And then the reg came out, and it landed with a proverbial thud, right? And they had to revamp it quite quickly to get anybody to play. And people remember, by the way, the cabbage demo, coronary artery bypass graft. We tried this payment reform stuff before. We tried bundling in the 90s. It worked. One fixed fee for doing a coronary artery bypass graft, what all of us did after we eat too much steak for 30 years, okay? Lowered cost, improved quality, but lowered income to the people in the cardiology profession. Guess what? They went to the finance committee and said, don't you dare do this nationwide. And we didn't. And that's the point. The budget world notices. Politicians respond to that pressure, and we don't always have the courage of our convictions. The mixed results out there are real. There's a lot of really good stuff going on in the medical home payment reform stuff, but a lot of it's not actually saving money, and that is the point, let us not forget. We want to improve quality and improve patient care, but if we don't save money, we're wasting our time. And there's a lot of evidence that would suggest not everything's working like we wish it would. And there's a reality that a patient-centered medical home, while it is the most common intervention, in some cases, in fact, in a lot of the cases that are actually being applied, is a zero-sum game between the plans and the primary care on the one side and the specialists in the hospital on the other. Let me tell you a secret. All the money is spent in the specialists in the hospitals. I don't know about you, but you might want to try to incentivize them too. So fundamentally, We've got to figure out a different way to get everybody at the table pulling in the same direction. No one's market share is enough to do this, which is why I was going to preach, but I don't have to. Collaboration. Y'all got to get together and do this, because none of you are strong enough to drive what you got to drive. And by the way, it's not entirely clear we have the courage to do multi-payer payment reform, but I have no doubt that is exactly what we need. Now, here's some numbers on Virginia. I'm going to go through these pretty quickly, but I'll just say, just like Bill said, we're doing pretty well, about the national average. But see, I moved from Arkansas to Virginia. I'm no longer happy with the national average. I would have been proud as hell to have the national average my whole life growing up. But we can do better than this in Virginia. Your costs, your premiums are right at the national average, a little bit below. Okay? Your total spend per person is about 8% lower. Your Medicare spending is actually 15% lower. All right? Your Medicaid is a little bit higher. That's probably because of case mix here versus the nation. But my point is, you're just about rocking along in the middle of the American economy's healthcare purchasing, which is, let's not forget, the least efficient purchasing in the world. Now, let me show you a little bit more detail about what's going on here. Remember that notion I focused on premium relative to income? Well, because Virginia is a relatively high-income state, our premium to income ratio, premium to median income, is only 17% versus 20%. That's the good news. Bad news is we've gotten to where it still costs so much, we've pushed more onto workers, so that if you're at a firm under 50 in the nation, typical worker pays 29% out of pocket. In Virginia, you're paying 41%, which is exactly why there are relatively few people covered in Virginia who work for small firms. And guess which kind of firm is more common? So we do have problems. We cannot be complacent. And here's what I would say is some really interesting numbers that came out about 2 weeks ago from the Feds finally released this stuff. And Chris Bailey is going to give me a hard time about this, I'm sure, because it's true. None of these numbers are actually paid by any human being known to man. But this does show the range of premium, of costs that are applicable and that are part of our system. And what I want to show you is while Virginia's averages, that's the red number, are a little bit lower than the nation, look at the range here. And by the way, you know, it's PowerPoint, I had to shorten. It's not just breathing, it's breathing on a ventilator, okay? But look, the cost range, there's a little detail going on there, but let me tell you, so the mean is 51, but the range is 6-1. How many other industries can tolerate and sustain a 6-1 price differential? And you keep going down the list. Somebody's paying some version of those prices, and it ain't Medicare, I promise you. It's the private sector, and that's the problem. We got to figure out how to deal with this. Here are the choices employers face. You could just compete, and maybe you'll win. Maybe you'll be the smartest buyer in the history of civilization. But you know what? You might want to think about doing exactly what Blueprint's about, and that's figuring out none of us are really big enough to solve this problem, but we can only solve the problem if we get together. So when is collaboration wise? Well, economics has something to say about this a little bit. When economies of scale from the necessary investment are large relative to any one player. Think about it. Why do we get together as a society to build roads and infrastructure? Because no one business can pay for the road. But if we all go together and pay for the road, then we got a road that'll improve the business climate. This ain't rocket science, okay? When no one knows exactly how to improve, who among you knows exactly how to save 20% of GDP off health care, 20% of spending off health care? That's what I thought. So we're going to have a meeting in the back. So we got to work together to pull this off. When the incentives are so bad that they've got to be fundamentally changed to support the necessary improvement. But here's the thing. Don't go yelling at doctors and hospitals, because it turns out they got to treat patients every second of every day. They don't have time to go read some memo I write and take 6 months off. They got to keep going as they're doing it. That's why it's going to take serious collective action. When the basic level of trust exists, or it can be cobbled together and maintained with incentives, absolute key to life, and data. Data, 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 data. Here's what leaders are saying around the country. This is David Howes, president and CEO of basically a bunch of primary care clinics, but he figured out life is so bad he better make his own health plan up there in Maine. And look what he said. The age of competing for market share by controlling access to data is over. Transparent, all payer data should be made widely available, and competition should be based solely on performance. This is from testimony by somebody from Maine. I will tell you, there's a lot of wisdom in that. So the federal government actually, in its own wisdom, has gotten some of this in their ideas, and they've got these multi-payer advanced primary care practice demonstration sites. Notice where they are mostly. North Carolina's in there from the south. Comprehensive Primary Care Initiative. I know some plans from Virginia tried to do this. And basically all this is about is trying to figure out how to pay primary care smarter so they will be incentivized and empowered to manage chronic conditions. The whole state of Arkansas, I'm so proud of them, Colorado, Oregon. And in here, the State Innovation Model Awards is something we hope to win pretty soon with Beth Board's help. But I will tell you what the vision of all these states is getting all payers to do similar things. Why? Because you got to move clinicians in the same direction. And notice the map of who won the state innovation models and who's got all payer claims databases. Kind of correlated. So what must communities do? Well, first you got to convene a table. Y'all got that. It's called a blueprint. Second, you're going to need some help. Okay, I don't know if you recognize this Arkansas implement. It's a crowbar. Because turns out there are people on the planet who are nervous about coming to the table. And I'll just be blunt about it, even though some of my best friends work for health plans. Plans are scared. Everybody's scared. All bad behavior is based on fear. You know, forgive them their fear. You're scared too, and you know it. They're scared. They're not going to have a place at the table. And there are people in Washington who would put them out of business. Thank God they don't have majorities. But, you know, weird stuff could happen. They might get one someday. So they're worried. But you're going to have to make them come to the table because you need them and you need their data. And it turns out the only human being who can get plans to come against their will is employers. Why? Because you write the check. You write the check. Don't ever forget that. Then we're going to have some partnerships. We're going to have to collaborate to pull this off. These are techniques for creating these kinds of conversations. But you don't need that. A, you got a blueprint going, and B, you got the Virginia Health Innovation Center already. Created very much part of Secretary Hazel's leadership, part of the VHRI, 501c3 housed at the chamber. Thank you, Barry, for doing that, because it sent a signal, if nothing else, that the business community is behind this conversation. We are going to make Virginia #1 in the country, and we can. Seed money from Hospital Association, Medical Society, and health plans and others. And you surveyed the state, found over 350 existing examples in this Commonwealth moving in the right direction. Who knew? 6 task forces are now making proposals, all that stuff. And here's what I really love. It's led by the private sector actors in cooperation with the state. What I have come to know is the Virginia way. Here's what you want to collaborate on. Data, data, data. Absolutely no reason not to take your clinical data, put it with your claims data. Don't put it in the Richmond Times-Dispatch, but put it in a room and use it analytically to figure out how to do it. You can tell them details, give them tables, but not the, okay. Coordinate on quality measures. Every clinician I've ever met, and I'm old enough to have met quite a bit, wants exactly one set of reporting requirements, one set of patient acuity adjusters, one set of incentives. You give them that, they will take you to the promised land. That's what they went to medical school for. You give them 40 different versions of quality metrics, and they will close the door. So I would also say you can collaborate on payment structure, not payment level. You do not want Aetna to pay the same as Cigna, the same as United, the same as Anthem. You want that competition to continue. But the structure, again, what clinicians need is one set of incentives. There's no reason on God's green earth you can't get them all in a room and agree on the structure. Then you go out and you argue about individual levels, just like conversion factor of the Medicare payment structure. But to do that, you're going to need a little help. Diagnostic treatment protocols goes without saying. I would also say you work out these optimal risk-sharing contracts with providers, and that is the future. They are going to have to bear risk. Treat those contract structures, not detailed levels, but structures, as public goods. That's what they are. They're infrastructure to make our healthcare system more efficient. And here's what you still compete on. You compete on patient experience and risk-adjusted outcomes. You compete on total cost of care. And the men at this table know, in the business community, that sometimes the cost of absenteeism and the cost of presenteeism is actually higher than the cost of health care on certain problems. Depression and blood pressure management come to mind. People show up because they got to get paid, but they're not doing anything. And that's why it makes a lot of sense to be smart about how you invest. You can compete on quality execution. You can compete on, can I continually get better. Here's what you need to succeed. You got to change your attitude about who owns the data. You own the data. Employers own the data. Plans are clients, partners, but you own the data. You got to change all attitudes about collaboration. Sounds like y'all started that. I won't preach too long. Arrange for state action immunity. I talked about getting them all in a room and deciding on a structure. Here's the reason. The deal is this, though. If you tried that this afternoon, you'd get arrested because it's antitrust. We have a term for that in economics. When you can't do what makes a lot of sense, it's called stupid. So what you want to do is get state action immunity, which means somebody from the Attorney General's office. I'll leave you to pick which one, but you want somebody from that office to come and basically sit there and don't fix prices, but you do talk about incentive structure, sharing data, yada, yada, yada. Keep your crowbar close by. You're going to need it. And by the way, your own chamber endorsed, and so I won't belabor the point, but Medicaid expansion is an absolute prerequisite to pulling this off. Because Hiles Hospital is going to be a partner if you don't solve our uninsured problem. And the uninsured problem is only going to keep getting worse because healthcare costs keep growing. You got to do that. Just, math trumps ideology just for different people at different speeds. And then keep close in your memory what happens if we fail. Let me tell you a secret. We are going to pay the Chinese back. They have a navy. There's 1 billion of them. The language is too damn hard to learn. We are going to pay them back. Question is how? We could do it smartly or we could do it dumbly. It's your choice. Thank you very much.